tonight to discuss African Americans' contributions to science and education and how those contributions have led to medical breakthroughs in both STEM and COVID-19 research and education. Along with Dr. Akintobi tonight, we also have other esteemed panelists joining us. So tonight we have Dr. Calvin Johnson, who is with Cedars Sinai Medical Center. Ms. Teresa Akintonwa from Black COVID Survivors Alliance, as well as the Recover National Community Engagement Group. Dr. Jimmie Smith Jr., who is the Vice President of Georgia Public Health Association, as well as an administrator with Macon-Bibb County Health Department. So tonight we're going to ask everybody to please engage in our discussion. So if you have any questions throughout our conversation, feel free to raise your hand and or type your questions or comments into the chat. We want everyone to know that this is a safe space, so we encourage you to ask questions and feel free to share your thoughts and beliefs about the topics that we discussed tonight. Going to start off by grounding us a little bit in why we're gathered here today. Why are we having a conversation about COVID and vaccines, and why this conversation is just as important as it was in the past and throughout our moving forward as we start to collect and gather in public spaces. So when we think about closing the vaccination gap, as of just a week ago, February 21st, there were more than 17,490 people who were hospitalized for COVID-19 in the United States. And while this is down from the 43,000 at the end of November of 2022, according to the Centers for Disease Control and Prevention, it's still important to note that COVID-19 is still a present threat. From mid-December to mid-February, the 7-day moving average of cases has decreased from 32,000 to 22,000. On February 15th, so almost a little over a week ago, there were 25,766 new hospitalizations from COVID-19. This is a 0.7 decrease, or 0.7 times less than the average of hospitalizations from 2 months ago. So we are seeing improvements, but as I mentioned before, COVID-19 is still ever present across the country and in Georgia. Particularly in Georgia, the Omicron variant represents 100% of COVID-19 cases. From just last week in Georgia, we saw 6,949 cases across the state, which is down 13%. We saw a decrease in hospitalizations, down by 11%, as well as a decrease in deaths, down by 24%. And so these decreases are important to note because what we are seeing is still an ever-present spread. And with that spread, we're seeing more mutations of the COVID-19 virus. So as I mentioned earlier, the Omicron variant that is prevalent across all of Georgia's cases is believed to be 105% more contagious than the Delta variant, which is known to be 50% more contagious than the original COVID-19 strand. Another subvariant that is present is the XBB 1.5 Omicron subvariant, which is believed to be the most contagious of all the variants. So it's 60% more contagious than the original COVID-19 strand. Across Georgia, what we have seen and across the country is an impact of vaccinations still working and vaccinations still being a powerful tool as we as a community fight against COVID. So the ratio of unvaccinated individuals who are hospitalized for COVID-19 versus those who are vaccinated is about 25-1. So across the state, there are 6,095,175 fully vaccinated people in Georgia as of February 16th. And while we note the power of vaccination, there have been some breakthrough cases as far as individuals who have just received the primary series of the vaccination. Breakthrough cases are shown 63%. In regards to those who have received the primary series as well as a booster dose, we've seen breakthrough cases of about 37%. And then hospitalizations, 3.2%, and deaths at 0.7%. So once again, noting that COVID is still a present threat, but what we are seeing is the power and the impact of vaccination, and more importantly, the power and the impact when we share information across our communities. So with that, I would like to invite Ms. Teresa Akintonwa to just share a little bit, thinking about your knowledge and your previous experience in regards to Black history, your experience in STEM and education. If you could share how all of that relates to COVID-19 and low COVID through your work locally as well as nationally.
Sure, thank you very much. I'm glad to be here this evening. You know, we all know that the best way to prevent long COVID is simply not to catch COVID at all. And, obviously that might not be, 100% possible, but we can at least reduce, some of the different opportunities that come up for people to develop very severe symptoms and, severe cases or frequent cases of COVID. And right now we know that the public's trust in medical institutes can be a little bit shaky at times. And luckily, though, with the rollout of the vaccinations that we have had, people have learned that there really is a huge benefit to being vaccinated. And I think that the main thing that the public needs to remember is that the vaccine does not completely prevent COVID, but it definitely reduces your chances of having hospitalizations and of having very severe cases, as you've noted. I'm very glad to hear that the numbers are trending downward, and that's excellent progress. And definitely can see the results of not only getting vaccinated, but also keeping up with one's booster shots to help this happen. And so just kind of historically, we've had a tendency in this, distrustful relationship with institutions to kind of imagine in our heads that all of the people who are researchers and scientists are, this club of white cis men, right, who are kind of sitting in the background, being diabolical, and just kind of planning to take advantage and exploit vulnerable populations. But if you look at us right here, if you look at Georgia CEAL, you look at Morehouse School of Medicine, if you look at the NIH and its Recover initiative, there are plenty of people of color being represented, and not just, as, tokens, right? Not as tokens at all, but actually in positions of leadership. And that's extremely encouraging to me as myself having long COVID, but it should also be a vote of confidence for the public as well, to understand that, Black people are involved in the scientific realm, whether it's COVID or other types of diseases as well. All of that is very important to know, so that we can have faith and trust that, these very people who are in charge of the vaccinations, the development of the vaccinations, they have mothers and grandmothers and sisters and brothers, right? Just like you do. And so they're invested for the good of their family as much as they're invested in the good of the general public, And so I just think that's really important. And if you had that first slide, I just wanted to bring a picture in people's minds about what it takes for long COVID prevention in that first slide. So I'm sorry, I didn't see it on the end, but in any case, long COVID prevention really, comes down to two things that I strongly believe in, and that is health and research literacy. And, when you lack knowledge, you are also lacking the power to advocate for yourself. And so previously, as an educator in the sciences, sciences oftentimes gets cut as far as allowing in the curriculum for children to have a lot of hands-on experience. And so just looking at, the future of Blacks in the STEMs, I think it's really important that we keep and support, first of all, having a strong science curriculum in our schools. I think it's very important that even after high school, that people have a way to continue their learning, to get engaged even as citizen scientists, understanding what the scientific process is like. The reason I'm bringing that up is because, as for one example, in the beginning of the pandemic, a lot of people were very alarmed at how quickly the vaccination had come about. And that was, partly a lack of understanding, first of all, about the fact that, this was the first time in history that, everyone in the world was working on the same single problem and able to share information at, lightning speed via the internet, right? And so we didn't have that during the last pandemic back in the 1918. And I think that's something important for the public to realize, that, with so many people teaming together to create the vaccination, that's how we were able to speed it up. And then in addition to that, we also know that when it comes to the coronavirus itself is not brand spanking new. We know that the coronavirus has existed, a form of it has existed. Coronaviruses in general, they tend to cause cold and flu. And so scientists were not starting at ground zero when it came to understanding, some of the basics of coronavirus. But it was just, the minutia that was related to COVID-19 specifically. And so when you have that type of baseline understanding that, this was not developed too quickly, but this was developed, intentionally, with the help of, basically all the brightest brains of the world, put together. With that information, you can go into receiving your vaccination with more confidence. And you can go into your vaccination understanding that there's, there are bodies, regulating bodies like the FDC, who are in charge of making sure that the development of these things are indeed safe, for not just adults, but for children and people who are pregnant, et cetera. And so, just overall, I think that we have a great opportunity with the presentation of COVID to really encourage people to consider, careers in STEM. And, you don't always have to, have been a doctor. You don't always have to have, be a scientist to get involved as a citizen scientist. One of those ways that we encourage people in our organization to get involved is to consider becoming a patient representative with the Recover Initiative. That's one way. Another way is for you to link up with a local organization so that you can participate in community-based participatory research, and also just volunteering as well as a patient in a clinical trial. If you could show the next slide, please. So, I just kind of assembled just a couple of health research heroes. Looking historically, we've often heard about the injustices, but not enough light has really been shined on, the benefits and the various heroes that arise out of, the research realm. And so one thing that people have heard, for example, with Henrietta Lacks, she contributed to the world HeLa cells. And there's a tendency for people to kind of pass this narrative that they stole her cells or her tissue. But they kind of just stopped right there, unfortunately. But there's a lot more to the story. Sure, at that time, they did a biopsy to retrieve some cells that were cancerous to take a look at. They didn't get her permission for it, et cetera. But from that, we have birthed a whole genre of science and genetic research, viral research. The polio vaccine was able to be created because of Henrietta Lacks's cells. Being able to count chromosomes. They previously used to think that there were 24 pairs of chromosomes, and they found out, by being able to look more closely that there, are 23. There are medications that have been created for treating sickle cell anemia and even curing sickle cell in some cases, doing gene therapy and even the HPV vaccination. And so I put all that in there, just to show that, look, though at that time, her family or she might not have gotten credit or the financial benefits of having shared her biospecimen, we have so much that has been contributed to the world's health, to our longevity, simply because of this one woman. And I encourage people, to consider, how can you be involved? Another person that is here, and I'll wrap up in just a second, Dr. Kizzmekia Corbet. She was a lead scientist. She's also with the NIH by happenstance. I just found that out. But she was one of the key scientists who was leading the development of the Moderna COVID vaccine. And so you can see that we have, modern day, right now living, Black people who are involved in, looking out for our welfare, making sure the science is done right, making sure the science is done as safely as possible. And I think that, we owe her, as well as, so many others who are behind the scenes that we just don't get to see enough of during this time.
Thank you so much for highlighting past and present pioneers and contributions to this field, particularly when we're talking about COVID and COVID vaccinations. So that's great to see, and we really appreciate that insight. You also elevated the work of Georgia CEAL as well as Recover. So I wanted to ask Dr. Akintobi to please share a little bit more about Georgia CEAL and the Recover work.
Thank you so much, Carrie. And I think my comments coming after those of Ms. Akintonwa are so very important. So, she talked about the importance of the work of minority leaders who really have been standing in the gap in terms of developing and leading the science and the conversation surrounding not just science, but recovery from COVID-19. And so all the folks who are on this panel represent those leaders as well. And so Georgia CEAL is a community engaged alliance against COVID-19 disparities. And so that means the ways that we conduct community-based participatory research with communities. And we didn't start doing that because of Georgia CEAL, but we've been doing it for several decades. And that means elevating the position, the power, and the voices of community and patient groups that need to teach us how to best engage them in science. And need to teach us the best ways to communicate based on their justified hesitancies in making life decisions. I know when I make any life decision, I need to pause before I make that decision. And so for something brand new like the COVID-19 pandemic, we expect that people will need information that is normed to where they are, who they value, and what the right messengers should be. So Georgia CEAL is designed to address issues that we know have evolved over time. First, they started with making sure that there were enough minorities and those that were underrepresented in vaccine trials. It's always been about communication and education. Then came the vaccinations, then came all of the variants. And so as this whole process have evolved, we've engaged partners like those on the panel, as well as others, including the Recover Initiative, to walk us through as we collectively journey our way through recovery and things like long COVID. So it takes clinicians, it takes those who are continuing to promote vaccinations like HealthWorks. It takes all of us in the public sphere to do that. And so we're really excited about the opportunity to continue the conversation of knowledge, of trust and bravery to make sure that everyone who is disproportionately impacted gets what they need in the amount that they need it to be able to live their best lives with the pandemic and past it. So we're really excited about this conversation, and I look forward to all the great insights that are shared today.
Thank you, Dr. Akintobi. And you spoke a little bit about this idea of being well-informed and how do we ensure that we're addressing maybe some misinformation or misunderstandings amongst communities about vaccinations, about COVID-19. So Dr. Johnson, could you mind maybe expanding that conversation a little bit and speaking to some of the misunderstandings about the COVID-19 vaccine and boosters, a little information about how long it takes for a vaccine to be created and approved, and even any insights that you have on long COVID as well?
Well, first off, there are three main types of the COVID vaccine, and none of the vaccines have live virus. None of the vaccines interfere with your own body DNA. They don't enter our cells, and so you can feel safe that these vaccines are not things that will genetically change you. As far as how long it takes for a vaccine to get tested and manufactured, tested, and delivered, it can take 1 or 2 years. It all depends. The unique thing, which was alluded to earlier about the COVID vaccines, is that the work on the coronavirus, the work with the mRNA vaccine had been started 10 years prior. So the data that had been was already there, the information was already there, the testing results were already there, and for the emergency utilization authorization to take place was a limited clinical trial to finalize patient safety and efficacy. And that was what was crucial. So the COVID vaccine was not something that developed overnight. It had been built on for many years. As far as long COVID, there's the things with long COVID that we've learned is that it has a higher prevalence in women greater than men. And that may be due to the fact that you have an autoimmune disease tend to be more prolific and greater incidence in women rather than men. And that may be the cause of it with estrogen. The other thing is that there's also the viral load, and that can also be something that, just like with HIV and herpes, the greater the viral load, it doesn't appear to be any race predisposition. It tends to be can be more related to getting Paxlovid early in the acute infection, and then which can then stop the viral load and reduce it to develop long COVID.
Let's talk a little bit about resources. So Dr. Smith, could you speak a little bit about resources that people can get related to COVID, particularly possibly at the Macon-Bibb County Health Department or through Georgia Public Health Association?
Sure. Certainly, I'd want to, again, welcome everyone that's participating tonight, and certainly thank you for letting me be part of this panel. I think my responses will speak, one, to what a local health department can do, and certainly as the Georgia Public Health Association represents those team members across the state, then the things that I'm going to say you should be able to find in all 159 counties here in Georgia specifically. So in terms of services offered, as the other panelists have said, certainly COVID-19 vaccines. Now, with that, again, you should be able to find those, or they are available in all 159 health departments. What may vary is the selection of which vaccine is available. So as you know, there was the Moderna vaccine, or I'll use layman's term, Moderna vaccine, the Pfizer vaccine, and then the J&J vaccine. Initially, when we started our response here in Macon in Central Georgia, we only had access to Moderna vaccine. And we were probably 6 or 7 months in before we even got any Pfizer vaccine, and probably 3 months in before we got any of the Johnson & Johnson vaccine. But there were certainly 3 out there. At this time, I can tell you in our area, I don't even have Moderna vaccine anymore. Now all we have is Pfizer. So that selection may vary, but all of your 159 health departments in the state can certainly supply their citizens with the vaccine. The second thing is we also have a ready supply of self-testing kits. I think all of us remember when we were getting tested for COVID early on, there were folks who were like, I don't want another brain biopsy. I'm having them twice a week, because it just felt like the swab had to go, almost to the occipital lobe just to be tested. But we have those tests, and they're readily available to pick up in any health department. And we still encourage people to do it, basically because of the information you provided before on how the transmission of the different variants has gone. So certainly knowing that it's more transmissible now, then we want people to know if they're positive so that they can take precautionary measures. The other place that I think public health at the local level has played a great part is trying to provide accurate health promotion and disease prevention guidance. I think all of us, whether you're the physician, you're the researcher, you're the community advocate, have all had to deal with misinformation as we've gone through these last 3 years. And I think COVID has really put a spotlight on that, more so than any other disease that we have. But I think there are certainly some lessons that can be learned from this COVID experience of how important that accurate health promotion and disease prevention conversations are. And for many of us, it made us have very lengthy, very repetitive, redundant, conversations. You felt like you were telling the same folks the same thing day after day after day. But I think those are the things that need to happen to move us forward from a health standpoint. A couple of other things, I think one of the things that public health has helped with, and certainly this is where I encourage the community to become more involved with public health, is certainly hold public health accountable for data. There's lots of data that was collected in the community. I know here in Georgia, initially we were giving vaccines, but we couldn't get information on were there disparities in who was getting the vaccine. Was it, we had a graduated rollout. We started with our more seasoned population, but in terms of getting data, are African Americans getting the vaccine at all? I am very proud to say in Macon-Bibb County, when I look at those numbers, there was a period, probably once we were given vaccines after about 4 months, the number of African Americans that received a vaccine in this area exceeded any other group. And most folks listened to that and they were like, no, that can't be true. We're not coming to get the vaccine. Like, yes, we are. And when that grandmother came to get the vaccine, then she told her son and her daughter and her grandchildren, and they came to get the vaccine. So once one person got it and then began to have those conversations with others and have the right conversation with others, then people continue to come. We started this conversation this evening with the numbers of people that had received the vaccine across the state, and it is certainly not enough as a state, from a statewide perspective. But when you begin to disaggregate the data and look at certain pockets within the state, then it is certainly far worse in some places than in others. I would also tell folks, when you're dealing with public health, ask for that data for your community. When you get that data, don't be afraid to ask why, what if, and why not. And I think because of the nature of how COVID came about, the research that had been in place for 10 plus years in terms of developing mRNA vaccines gave us some new, not new, but in some cases forgotten methodologies of how we're able to serve the public. So think about the things of, we were delivering vaccines to the homebound. I'm a residency trained family physician. We had to do that when I was in residency. When is the last time you've seen a physician come to the house? Those things have changed, but the practice still works. We had mass vaccination sites. Think about if we took that method from COVID and said, you know what, we're going to have mass sites where we're going to check blood pressure. We're going to check glucose levels. We're going to check folks that have diabetes, and we're going to check their extremities. You can take those lessons from COVID and move it forward. We saw a great use of mobile units, taking vaccines into the very communities that may not be far from a health department or a healthcare facility, but for whatever reason, those folks would not access the facility, but would utilize the services when they were brought to their community. And there was that trust that was built. We saw several public-private partnerships get initiated and now being sustained to help in this effort. And then the last thing, which I don't think we need to forget, is we also need to look, when we're looking at data, as to who was included, but also we need to do a very honest assessment of who may have been excluded. So when I look at communities, as a health department administrator, every day I get up and know I've got 157,000 people that I've got to watch out for, whether they see me or not. And most times you don't want to see the health department director anyway. But what about those men and women that are in our correctional facility? They may be confined, but they don't need to be excluded. So we wanted to make sure that they also receive the vaccine. The last thing I would say about what COVID has taught us is, and this is a positive, is it introduced public health to parts of the world that had never seen it. And keep in mind, we've had vaccines here. There are parts of the world that still don't have vaccines. And certainly we haven't taken advantage of all the vaccines we have, but I also saw undergraduate students, graduate students across many disciplines become contact tracers. And they were able to engage in public health and move things forward to help in this effort. So I think in those respects is where public health has tried to, excuse me, put their helping hand in with COVID. But I think just because we seem to think COVID has kind of shifted or beginning to play out, we still need to stay as diligent as we have been to move those same mechanisms forward.
Thank you, Dr. Smith. And I think you touched a lot on making sure that all members of our communities are included in these conversations, are represented in this data, and that we are responding in an equitable way. So when we talk about, excuse me, health equity, Dr. Johnson, could you share a little bit with us about maybe some potential challenges or as well as some potential successes in advancing health equity when we talk about COVID-19?
Sure. First slide, please. I think that first, what I'm going to do, I'm going to we're going to take a journey of the past, present, future as it relates to health equity, diversity, and preparing our next generation through the institutional lens of Cedars-Sinai Medical Center. Since its inception in 1902, the Cedars-Sinai Health System has embodied the principles of health equity and the fight against prejudice and racism. It was founded as the Casper Kahn Hospital, the first Jewish hospital in Los Angeles, and served a new immigrant community that faced prejudice on a regular basis. Our hospital's founding was a statement that not only would the Jewish community have a medical refuge, but that all Angelenos were welcome as well, irrespective of race, religion, ethnicity, or ability to pay. Our history of health equity is deeply rooted in the Judaic tradition, driven by the values repairing the world and righteousness. The article listed details from its inception to the present day of Cedars-Sinai's commitment to health equity and the fight against prejudice and racism. Next slide, please. Cedars-Sinai Medical Center, poised and ready for the pandemic. This is how it all happened. In 2019, President and CEO Tom Prisolek established the Office of Health Equity for All Patients and the Office of Diversity and Inclusion in the Workplace. Cedars' pre-COVID commitment to health equity and DEI positioned it to respond immediately, compassionately, and effectively to meet the needs of Black and Brown communities during the pandemic. Community outreach was established immediately, involving COVID education, working with churches, community centers, town hall meetings, establishing vaccine clinics, partnering with doctors, with Black Doctors, .org, which work with the community physician, community clinics, et cetera. An establishment of the COVID long recovery program by Catherine Lee, MD, the director, which demonstrated that women were more susceptible and that providing Paxlovid during the initial infection reduces the risk of long COVID 10 to 30%. And that the lack of Paxlovid access and or COVID vaccination in underserved communities may predispose to long COVID. Next slide. Cedars and its STEM projects. Where there is no vision, the people perish. That's a very, that proverb really hits home for me because it's a vision that we must give our communities and our young people. Cedars STEM school programs consisted of Cedars faculty going to elementary and middle schools with large Black and Brown student bodies to talk about medicine, research, and clinical care opportunities. And then there was the Cedars STEM Simulation Center program that brings elementary and middle school students from lower socioeconomic backgrounds to get hands-on experience and exposure to medicine, anesthesia, surgery, to provide a vision in STEM. Cedars supports the Black men in white coat. Why the need? Black men have the lowest life expectancy in the United States. Less Black men applied to medical school in 2014 than in 1978. In 2018, only 2.6% of U.S. physicians were Black men, and 2.8% were Black women. Medical schools share some, but not all, of the responsibility in addressing this problem. Provides a vision for Black and Brown children to pursue a career in medicine. Promoted the inaugural release of the documentary film, Black Men in White Coat, February of 2021. Continues to promote. In May of this year, 2023, Cedars will host the Black Men in White Conference in White Coats Youth Summit in LA. Next slide. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Based on this, Cedars-Sinai has partnered with and has a collaboration with the Charles R. Drew University of Medicine for its first 4-year medical school. Under the direction and collaboration of Dr. Mark Noah, Vice Chair of Medicine and Associate Dean of Education for Cedars, is coordinating this collaboration, and Cedars physicians becoming teaching faculty for the new CDU 4-year medical school. The inaugural CDU 4-year College of Medicine is starting this fall, 2023. It will mean that it's the only Black medical school west of the Mississippi. Cedars embraces the societal need and responsibility for promoting equity in healthcare for all people. Next slide. Here are the women and men contributing during the pandemic. You have Gabriel Hunt and Lionel Hunt, spine surgeons. They're the only Black brothers who are spine surgeons in the world. Gabriel is a neurosurgeon trained spine surgeon. Lionel is an orthopedic trained spine surgeon. The two of them combine both specialties to provide care during the pandemic. We have Christina Harris, MD. She's the VP and Chief Health Equity Officer for Cedars-Sinai. She is the lead for providing health equity within the institution, as well as in our local Los Angeles communities. James Turkin, PhD, Professor of Medicine, Research Scientist, Cancer Institute for Cedars-Sinai. He is a pioneer researcher for the STAT3 cancer, which is a biological way of addressing drug delivery. He is the founder of this research that is so vital for treating our cancer patients, as well as he is an advocate for minorities getting involved in clinical trials related to cancer. Dr. Kimberly Gregory, she's professor and director of maternal fetal medicine, internationally known, and oversees the care of our 8,000 deliveries per year system at Cedars-Sinai. Keith Black, MD, founding chair of neurosurgery, brain cancer. He is the pioneer. He is considered one of the 21st century people of this century. His work in brain cancer has been nothing short of miraculous. We've got Milton Little, orthopedic trauma. He's internationally known for his work in correcting those injured parts of the body that have been destroyed by trauma, and stood in the gap preparing patients during COVID. Michel Condi, MD, he's a cardiologist, critical care. He functions in the most critical, most severe scenarios, taking care of patients. He's internationally known for his care during COVID. Joanna Chikwe, MD, she's the founding chair of cardiac surgery, internationally recognized for her cardiac surgery, as well as the lead and oversees the heart transplant program at Cedars, which does more heart transplants than any other place in the world. Alice Coombs, MD, chair of anesthesia at Virginia Commonwealth University. She is an advocate for women in medicine, member of the AMA board. She has been instrumental in overseeing just the care of during these patients during COVID. She was appointed chair of VCU in 2020 and is the first female and Black chair at that university. Seung Johnson Acute, he's the chair of anesthesia at MGH. He is world renowned for his work in neurosurgical anesthesia. He received the highest award that the American Society of Anesthesiology gives in his work with neuroanesthesia. He carried and provided the care necessary via the anesthesia department during COVID. He is the first Black chair of anesthesia at Massachusetts General Hospital. When you look at these faces, these are the women and men that provide inspiration and vision to our next generation, regardless of gender, race, or religion. And this gives us hope for humanity as we move forward in healthcare disparity. Thank you very much.
Thank you, Dr. Johnson, for highlighting those pioneers at Cedars, as well as some of the strategies and initiatives that you all are using to engage African Americans in STEM and in research. I would now ask Dr. Akintobi, when we think about that engagement and ensuring that African Americans are ever present and continuing to share information with each other, when we reflect on the history of research, oftentimes, as mentioned earlier, what comes to mind is maybe some of those more negative experiences, like the syphilis study at the Tuskegee or other research efforts. So when we think about moving forward throughout COVID-19 pandemic, how can we ensure that African Americans and minority populations are less hesitant about protecting themselves in the future and are able to get the information and resources that they need for themselves and their communities?
Thank you for that question. I think one thing is that we need to give people the facts and the data. So our panelists and those of us across Georgia and many other spaces can really be great sources of information for details related to how the vaccines were developed, the science and the history behind it, as well as some of the more practical questions that folks want answered. The other part of that, though, is that we must ensure that in our approaches, even though we may, as Dr. Smith shared, have to answer a lot of the same questions over and over again or in different ways, we have to respect where people are. There is nothing like people feeling ostracized or stigmatized because they're not doing necessarily what might be the best thing. We have to meet people where they are, and that means respecting their position and doing a little relationship building towards understanding where it comes from, because it's through doing that that we can develop the best communication strategies that address their concerns and their justified and maybe sometimes not justified hesitancy, but we can only come from a position of understanding. And with that, people feel heard and more willing to listen to what the alternative might be that might be better for their health. The other thing that is important is that, while many of us represent training in public health, community advocacy, clinical training, research training, we have to be sensitive to the fact that we still represent, in many instances, the academy. And while we may look like the community, it's our responsibility to flip that script from doctor or clinician knowing best to communities really being centered, not just to support us in getting a bunch of people vaccinated or to recruit to a clinical trial, but they must be a part of the teams that help us to determine the best strategies and the programs, not after they're developed, but when we're even thinking about the right approach to consider. So one of my partners in Good likes to say, don't just bring me in as a community partner to pick the paint that's on the wall or the pictures that get hung up. Community residents and leaders should be a part of developing the foundation of our why, and not just active participants, but as contributors to exactly what the house should look like. And so Georgia CEAL and many of the other approaches that were described have really centered communities as leading, not advising the work. And so, we have partners across the state of Georgia that represent health departments, that represent those that work with Latinx and other priority populations, but across them, our priority is making sure that they are in the majority to tell us what to do in the ways that make sense. And so when people understand that our intention is to center their leadership and to power our initiatives, not empower because they come with their innate power, but to power our work with their leadership, then we demonstrate not that we're just here to address COVID-19, but that we are on an ongoing pursuit of trustworthiness. So that, I think, are among the pillars of how we can work the pathway forward, and not just as a moment in prioritizing public health, which is amazing, because my parents now know what I do, but that they understand that this really is a time for community-centeredness and community-powered approaches to be a movement towards how we tackle any public health issue moving forward. So they must be centered, we must be sensitive, respectful, and understanding towards developing communication strategies that matter now, but also into the future for what comes next. And there will be other things that come next.
Thank you, Dr. Akintobi. And in that sense of creating community, creating shared power, I want to invite our audience, if you have any questions for our amazing panelists, to feel free to share those in the chat or to raise your hand, and we'll be happy to make sure that you're able to engage in our conversation as well. As we wait for those questions to come in, I know that Dr. Smith was able to touch on some of the things, as well as Dr. Akintobi, lessons that we've learned from COVID and ways we have responded. So maybe those things that we want to carry on to future endeavors. Because as Dr. Akintobi mentioned, there will be future endeavors and future things for us to come together and ensure that our communities are strong against. So in thinking about that, I will pose this question to all the panelists. Considering that, the swift transmission of COVID-19 virus, there was an urgency, we needed fast action. It was the first time that we really saw people come together across the globe and work at the same time to solve a public health threat. So what are some of those lessons that we can learn from that fast response, from that type of collaboration?
Well, I think that one of the things is that we saw how when the world focuses on a single disease, how quickly treatment, vaccines can occur. It was the first collaboration of the world coming together. That has never happened before. COVID brought the medical world to its knees, and they responded with coming together. And I think that hopefully the door will stay open so that there will be more worldwide collaboration as we look at other diseases, such as cancer, such as things related to health care disparities. How can we address these things on a worldwide, from third world countries to here in our cities in the United States?
I would like to add to that. I think one of the great lessons that COVID taught us was that health is the great equalizer. When we saw the nightly news with the numbers of the people that had succumbed to COVID-19, you didn't see those numbers and they said, well, this many white people died or this many Black people died. It was an equalizer because it was everyone. I think at the same time, it also shed a light on the fact that though we all live on the same planet, we function in different worlds. And I certainly know my panelists understand that with the science world you've had to walk through and the training you've had to get to be in the seats that you're in right now, which is why again, it's so important, as Dr. Akintobi said, to have those repetitive, redundant conversations, meet folks where they are, so that they then can make the best possible decisions for themselves and their communities. But not everyone, we certainly felt we were all in the same boat. I say we were all in the same storm. But there were some that were on yachts. There were other folks that were on tugboats.
Yeah.
There were a few of us that felt like we were in a little John boat and the motor broke. And, we just trying to get from one place to the other. But I think if we go back to what makes us like science, makes us like medicine, makes us like research, then we can take this forward. And even though health is that great equalizer, then we start from a level playing field.
Thank you for that. We're going to start going through some of the questions that are coming through in the chat. So one being, I guess, let's all increase our science knowledge a little bit, but someone asked if you could explain a little bit more about viral load and its impact. So when we talk about COVID, I know we could be here for a full hour on viral load, but if you could just share a little bit more about that.
Well, what's been shown is that there's a certain viral, it's almost like if it if you get an acute COVID infection, and I'm going to make the numbers small because this is how I learned. Say you got 10 viruses and you get Paxlovid, okay, and it gets rid of those 10. But let's say you don't get Paxlovid, or you're not vaccinated, and that 10 turns into 1,000. And that's what we mean by the viral load gets so high that now it can cross the blood-brain barrier, get into the central nervous system, and get into various organs that can lead to the development of long COVID syndrome. And it's so important that we level the playing field, as Dr. Smith has said, in terms of making access to treatment for acute COVID, vaccine, and all of these things that help reduce the viral load when you are infected with COVID. There's also some thoughts out there that perhaps it's still the waiting to be seen, but whether or not even Paxlovid might be used for long COVID. Now that is just out there. It's being looked at. So there's nothing substantial to report on that yet.
Thank you, Dr. Johnson. Another question that we had that came through was, how can COVID orphans be found, treated, cared for with community input? And I believe that question was posed by Richard Hector. So Richard, if you could provide maybe a little bit more clarification about what you mean when you say COVID orphans, just so we can make sure that we are addressing your question properly. That would be great.
Well, I think what has been looked at is that these are children in which the parents have died of COVID. And that's the term, COVID orphans. And how are we going to develop a system, a community system to take care of these children? And I think this comes from starting community programs, being in the community. Our healthcare systems need to be in the community, work with social services so that we can develop ways in which to take care of these children who's lost their, perhaps it was the grandmother that was taking care of the child while mom and dad worked. But this is going to be, COVID is going to be the gift that keeps on giving for the next 10 years or so. Socially, mentally, we saw domestic violence rise. We saw the rise in mental health because of all of the psychosocial effects dealing around the pandemic.
Dr. Johnson, thank you for that. I'd expand on that, that, all of those determinants of health, basically things that are barriers or facilitators to people having their optimal health, social services, neck up health, mental and behavioral health, linkages to workforce development, all of those things really are just, exponentially magnified since COVID-19. So it behooves us to develop those partnerships with those organizations who were doing that important work before. Those alliances are important. There is no way that all of us have the expertise in all areas, but there are organizations who have been on the ground for years and are here for such a time as this. And so this time requires those linkages to address just the issues that Richard brought up, because again, the ripple effect, the long-term effects of COVID beyond those of the individual, just as Dr. Johnson described, will be with us for a lifetime.
I'd like to add that, there's over 400,000 children who have become orphans due to their parents passing away to COVID. And that's an extreme burden, on our social services system. And it's going to be really important that we recognize that recovery from COVID is not just the medical aspect of it, but there are people who are suffering disabilities from this, people who are incurred new expenses and larger households because they're taking care of many of these orphans. And so as Dr. Akintobi said, that there are organizations who have already been in the trenches doing this work prior to COVID. And I think that it's important that we all try to connect with those organizations in your local area. Building trust and maintaining community engagement is definitely an ongoing work, as she stated earlier. And I think that, you don't look at yourself as not being good enough or informed enough or educated enough to participate, because you can. There are many ways that you can step into the arena and battle COVID. From, again, being just a community representative, a community volunteer. If you are a patient, if you've ever had COVID, if you've ever taken care of anyone who has had COVID, you have an opportunity to give feedback, to show, our policymakers and our health institutes what exactly is needed, to recover, not just on the medical side, but all those other resources that we need, help with filling out disability forms. Long COVID is quite serious, and it's quite unfortunate that we haven't seen other diseases make such an impact all at once, like it has. And so it's important that as much as possible, if you can volunteer, to participate in a clinical trial, do so. I showed you on one of the other slides, these young men who had participated in the clinical trials for sickle cell anemia and were cured of it. And so I don't want you to ever think of, research as being experimentation. We have so many protections in place now that was not in place back when a lot of the misjustices were, done to minorities and poor people. And so now with those new protections, now with people who are already invested in our communities, I think that you can have a vote of confidence that, you can get involved in something to help contribute, to this total recovery from the pandemic, as well as any future issues, which will definitely come. It's not about if, but when.
Thank you so much. Excuse me. For sharing that. As we close, kind of building off this idea of future public health threats, if each of you could please you've given us many strategies, things to think about, ways to be actively involved in protecting our communities. But if you could close with a 30-second call to action of how can people protect themselves and their communities from in the face of a future public health threat. So I'll start with Dr. Akintobi, and then we'll just pass it around in closing.
So I think being armed with information and facts is essential, but understanding that this is heart work and it is hard work. And so those are among the assumptions that are important for us to go. This is about people and partnerships towards, as was described earlier, as total recovery. And so total recovery takes time, especially when the systems that were there before were not perfect. So extend yourself grace in the battle towards this, and know that knowledge, education, facts, and heart all must work together towards recovery.
Thank you, Dr. Akintobi. Dr. Johnson, what would be your call to action?
My call to action would be for, just as has been mentioned, is that we need, as institutions, get involved with the communities. And that's one of the things I do applaud Cedars for, is getting involved with the community on the ground level and meeting people where they're at. You don't talk down to someone because they don't understand or they have a fear. No, you meet them, you listen to them, you hear their fears, you hear their concerns, you hear the struggles they have with not getting childcare to make it to the vaccine clinic, or can't get off from work. It's not that they don't want to get vaccinated. There are logistics that have prevented them. And so I think this is where ground level meeting people where they work from institutions, getting intimately involved with the communities they serve.
Thank you. Dr. Smith?
I would just certainly echo everything that's been said so far, but I would also remind us that, as has been said, COVID is going to be here. So as we move from what was, an acute phase to probably chronic, it reminds me of a quote that says, when you're born, you look like your descendants, but when you die, you look like your decisions. How do we as researchers help educate the community so that they can make those informed decisions for themselves to improve the quality of life they have while addressing the social determinants? We hear so much about people being resilient, but we're all tired and it's hard work. So how do we move from being resilient to just being ready? And that would be the thing that I would say that we need going forward.
Thank you. And last but not least, Ms. Akintowa, if you could share your call to action.
I'll just sum it up with, volunteer. Go to www.recovercovid.org, and that is your opportunity to find, what route fits for you as far as participating in research that ultimately will help everyone.
Thank you all for those call to action, and thank you all for joining us today for our town hall. We hope that it was informative and that this is just the start of a conversation that you can continue with others.